Okay, guys. Today our speaker is Dr. Felicio Faccarete. He is the cardiologist at Cardiovascular Solutions of Central Mississippi. He also has a background of interventional cardiology and interventional radiology. Also has fusion vascular, and he's going to talk about peripheral arterial disease and some of the things that they do there at their clinic. Okay. So a little background on Dr. Faccarete. He went to med school at Rutgers, and he did his residency at Cornell and had most of his cardiac training at Cooper. And then he belongs to a number of organizations, but some of the big ones are the ABC, which is the Association of Black Cardiology, where he's the PAD chair. The other one is SCI, which is the Society of Coronary Artery Intervention, where he's a vascular disease council member. And then also there's a really cool article out in ProPublica that has over 50,000, how many, Doc?
5 million.
Oh, 5 million, sorry, 5 million views, okay? It was featured on a lot of major networks such as CBS News and NBC Nightly News. I've had the pleasure of working firsthand with Dr. Faccarete. Changed my life, basically, the things that I've learned through him, okay? So he's got some really cool things to tell you about, some awareness on peripheral arterial disease, and then there will be some questions like Ms. Thompson was telling you about at the end, so pay attention, okay? This is important. All right, so y'all give a round of applause to Dr. Felicio Faccarete.
Good afternoon, family. How y'all doing? Can y'all hear me? I know with COVID it's hard to talk with a mask, and they would ask me if I should speak with a microphone, but I do best actually engaging the crowd. So yes, this is how I dress up to work. I am not your typical physician. My mom is a registered nurse. I grew up in Africa. I came to America when I was 13. And when I first came here, I knew I had a passion for sciences. I had a love for people. I knew I wanted to become a heart specialist. Actually, I wanted to be a heart surgeon. And that kind of pivoted during my first year of medical school. And so I say all that to say that, you know, the two advices I ever got in life, one was one from my mom, who's a nurse, who during my white coat ceremony, which is one of the kind of prestige ceremonies you get as a doctor, she said, the only advice I'll ever give you in life is that nurses will make or break you. That's it. That's all. That's the only professional advice I've ever gotten from my mother. And she's been a nurse for over 45 years. The second was from one of my mentors, who said that it's okay to pivot and change your career goals even during your professional career. So as I see just a crowd full of nurses who are eager to go and become the next great thing, for those who don't know, that day will come. It's okay to pivot at some point, all right? Don't be ashamed. Just know that mentorship is very important in everything you do. So today we're gonna talk about peripheral arterial disease and why I ended up in the Mississippi Delta. Having schooled in New Jersey, and you heard all the, New York is where I did all my training. I realized that we have an epidemic, and that epidemic is not only peripheral arterial disease, a disease that afflicts 200 million people worldwide. It affects 20 million Americans, but unfortunately, it is very more prevalent in underserved communities, particularly in the South. And if not caught on time, it leads to complications, and it upends lives and livelihoods. And these are going to be your patients, and you're going to start seeing them at a younger age. And so PAD is something that's not covered in a lot of curriculums, but I'm happy to hear that y'all have covered it. All right, good. So let's talk about peripheral arterial disease and compassionate care. If there's anything you see and you want to interrupt me, you raise your hand during the talk, okay? All right, good. Tony, who's also a grad from here, I have all my nurses, shout out to them, they're here. We have 5 who are graduates of this program. Tony's one of them, and he's gonna be my slide advancer, all right? All right, Tony, next slide, please. So before I always talk as a cardiovascular specialist, you know, Heart Month is Heart Health Month. It's not just Valentine's Day today. It's Heart Health Month, right? It's 1 in 3 Americans die of heart disease. Is that true or false? That is all false. 1 in 3 Americans die of cardiovascular disease. That is true. Not heart disease, but cardiovascular disease. Y'all will hear this in a lot of publications. And so before, I always highlight what is cardiovascular disease. Why does it kill 800,000 people each year? 1 in 3 women will die from cardiovascular disease. 1 in 2 black women in here will die from cardiovascular disease. 80% of these deaths occur in neighborhoods that are similar to ours here in Mississippi, right? Middle income, low income neighborhoods. That's where these deaths primarily occur. And 1 death every 38 to 40 seconds. 1 amputation every 30 seconds. It claims more lives than all forms of cancer combined. It is most expensive of all deaths. And nearly half of all black adults in America carry 1 risk factor for cardiovascular disease. Next slide, please. So this is cardiovascular disease. Coronary artery disease. When you have plaque buildup in your heart, you can do it. Good. When you're born with clean pipes, all right? Just think of your kitchen, sink, all clean pipes. But then there's certain risk factors that add up, and you have the buildup of plaque and cholesterol, which is known as what? Atherosclerosis, right? And that eventually clogs up your pipes, right? And then we start seeking out help after we have symptoms. I'm gonna pass this along so y'all start seeing that. There you go. And pass that back there. But that is coronary disease if it happens in your heart. If it happens in your neck, it's known as carotid artery disease, which can lead to stroke or transient ischemic attack, the TIA. Now, you have hypertension, high blood pressure, right? Or as our elderly folks call it, the pressure, right? That is hypertension. Congestive heart failure. Valvular heart disease, your valves are not functioning properly in your heart. Stroke, irregular heart rhythms known as arrhythmias. And you have a congenital heart disease. You were born with a hole in your heart when you were young. Or there are other findings that they found. And if you have peripheral vascular disease, a constellation of every single thing is known as cardiovascular disease, and 1 in 3 Americans will die from it. It's not just heart disease, which is coronary artery disease. All right? Next slide. So what do we know in regards to Mississippi? We know that our metrics are not great when it comes to outcomes, both morbidity and mortality data, okay? We have a very poor health literacy level. We have highest prevalence of chronic diseases across the metric. We have lowest number of physicians and actually nurses per capita. Lowest metrics on social determinants of health, and I'll explain that to you all. That is a very important topic that you have to understand as nurses. You lack hospital engagement with communities. A lot of hospitals do not engage communities to teach them about preventative upstream strategies. You know what they say? Well, just come to the emergency room when you get sick. Well, we're trying to prevent people from falling sick, so we need to go meet them where they are to engage with them and educate them, inform them so that it can be transformed. We have systemic inequities that lead to health disparities, and there's statistical discrimination in healthcare and underrepresentation. What does that mean? There are only 5% of physicians in America today that look like me. 5%. Less than 1.5% are cardiologists. That's who I represent. So when I walk into a town or community where I see people who look like me, there's certain things about their cultures I have to understand. And when I'm not from that community, I have to actually do a better job to educate myself about that community, learn about their strengths and weaknesses, so that I can better treat those patients who are from there. Next slide. So over the next 2 decades, unfortunately, African Americans are going to carry the highest prevalence of cardiovascular disease. Next slide. And when I talk about cardiovascular disease, peripheral arterial disease is not only the narrowing of blood circulation to your lower extremities, but what actually keeps me up at night is the consequences of it. Most of these patients will die from coronary artery disease, or having a stroke, or going into renal failure. So the co-prevalence of the disease is something you also have to understand. So 80% of these patients who have peripheral arterial disease will have coronary disease. About 50% will have some form of carotid artery disease. Another 25 to 50% will have some form of renal vascular disease. Next slide, please. So why does peripheral arterial disease scare people? Why should it scare you? If you look at this slide on this right-hand side, I can ask any one of you if you've heard of any family member who's had cancer. And you raise your hand, and it's scary when you hear the term cancer. Well, peripheral arterial disease is more deadly than most of the cancers you all know about. It's worse than prostate, skin, and breast cancer. Only advanced form of lung cancer or pancreatic cancer carries a higher mortality than peripheral arterial disease at its critical stage. So that's why you have to recognize it. It's not only chronic, debilitating, it's deadly, and it's prevalent. Next slide. But how many of you all heard of peripheral arterial disease before you came to this nursing program? Well, just a few. Good. Less than 25% of the entire population has heard of this disease, in spite of everything I just told y'all. That's the problem. But everyone has heard about cancer. Anyone who's watched a sporting event or you've been on a flight, you'll see all the awareness campaigns about cancer, but you've not seen one about peripheral arterial disease. So awareness is what we have to do a better job. That's why we're here today talking to you. Next. Next slide. So this is the prevalence of the disease. 20 million people have PAD. About 30 million have diabetes. 80 million people are pre-diabetic. 30 million people are diabetic. I'm sure your professors will tell you the difference. But diabetes is one of the major factors driving peripheral arterial disease. Next slide. So as I said, it's just the buildup of plaque atherosclerosis that leads to platelet activation, inflammation occurs. The endothelial lining of the blood vessel is disrupted. You form a narrowing of the blood vessel, and it leads to symptoms. But not everyone gets symptoms. That's the problem with this disease like cancer. Not everyone has symptoms. Next slide. So, if I were to tell you that you have a disease state and only 15% who do this, they walk and they cramp when they walk in, and when they stop, it goes away. What is that called? Claudication. Only 15% will have some form of claudication. That is what is taught in our medical school books. And that's probably what's taught in your nursing school books. But that's not what presents to our offices every day. You know what presents to our offices every day? Well, doc, I was at Walmart the other day and my leg gave out. How do I define that? That's not claudication. His leg just gave out. That's different. That's what we call atypical, right? Atypical pain. Like something happened that made that man or woman's leg give out. Or, my feet just burn. It just burns, numbness and tingle at night. I can't sleep well at night. Or, it's just different words based on their literacy level. So they classify them as asymptomatic or atypical, but they're only telling us, physicians and providers, to treat claudication. So you know what happens? Just like cancer, when it's slow, progressive, it's deadly, and it's silent, you don't catch this disease till when? It's the end stage. And it's known as critical limb ischemia. 2% of the population present with critical limb ischemia. You know what critical limb ischemia is? When you have that claudication symptom that occurs at rest, so rest pain, or you have a non-healing wound and ulcer, or gangrenous toe or foot. That is the definition of critical limb ischemia. That's when you know that this person is having a leg attack. Just like a heart attack, this patient is having a leg attack. Critical limb ischemia. Next slide. So what are the risk factors for peripheral arterial disease? All here. Age, greater than 50. Smoking, diabetes, high blood pressure, high cholesterol, kidney disease. Your race. If you're Hispanic, African American, or Native American, twofold higher. Your family history, genetics. All right? Next. So this is why if you're PAD, as I've summarized it earlier, we have a prevalent condition where the numbers are rising, diabetes rates are rising, obesity rates are rising. We have an increasing aging population. The fastest growing population in America are octogenarians. What age group is that? Anyone? Octogenarians. What age group? Anyone? 80s. 80-year-olds are octogenarians. 80-year-olds are the fastest growing population in America today. You know why? Because they have great nurses and doctors who are doing a better job of keeping them to live longer. That's why. We've had medical advancements, and so you're going to be seeing your grandparents with PAD symptoms. Next slide. So we've had multiple studies showing the disproportionate rates of high amputation rates in minorities. Next slide. And we have articles, as Courtney Evans mentioned earlier. Just wanted to highlight how institutional policies and medical practices and systemic inequities, which are basically lack of things that should have been instituted preventatively upstream, are missing in our healthcare system. And if you chronicle it, the best way to tell a story for all y'all who are gonna go into presenting, don't just come and talk about a disease, make it personable, humanize it, bring patients to the forefront. Let people hear their voices and their stories. So we did that in this article. I will email you a copy. It's a very long article, but it just tells you about what's going on around us here in the Delta. Next slide. But this is a story. This is a young lady who came into my office, 49 years old, African American, who had diabetes and end-stage renal disease. The #1 cause of chronic kidney disease in America today, and why people are on dialysis, is diabetes. So her diabetes, which was not well treated, led to end-stage renal disease. And she came in basically with dark toes and gangrene foot, and also gangrene in her fingertips. She had been followed by a wound care center for months. No one knew what they were doing. And she went into renal failure, couldn't put together that the diabetes was what caused this. She had a 12-year-old daughter. She wanted to be a correctional officer, so she had a vision of what she wanted for her life. Unfortunately, because of her condition, she lost both legs, so above the knee amputation. And you see those fingers, 7 fingers were actually also amputated. So that's a 49-year-old female. Here's the saddest part of amputations. For all of you who know an amputee, as long as you undergo a major amputation, meaning any amputation above your ankle in America, 80% of them will die within 5 years. That's the death rate for a major amputation. 80% will be dead within 5 years, if it's due to peripheral vascular disease. All right? So that's her hourglass. It's flipped. And sad news on top of this is that she just lost her mother from COVID a week ago. So her caretaker, who you can see in this picture in the background, is no longer here. So think about the clinical, economical, and human impact of Denise's life. And then bring that into your household and make her your sister. That's when things start that's how I think about every patient. You personalize it. Next slide. So, how do you start identifying these patients? One, your history and physical, very important. I know y'all have gone over that, right? It's understanding the disease, knowing your history and your physical. Knowing what peripheral arterial disease is interesting. So do they come in with numbness, tingling, burning? Do they have discoloration of their foot? Have they had hair growth that is just abnormal? The toenails, do they look different? Does anyone take off their socks to check their pulses, as they should in every visit? So those are the things that you start looking at. Do they have any wounds or ulcers? And then the next thing is you do what we call an ankle brachial index or ultrasound, where you see what their values are, and depending on if they're normal or abnormal, you refer them for further screening. And then just always remember that there's also alternative diagnosis for leg pain. Next slide. So, if someone has numbness and burning, that is a diabetic, that I did an ultrasound and it's normal, but tells me that they've had back surgery. They have a radicalopathy. That's what's causing the numbness and burning. Totally different pathology. If someone has osteoarthritis of the hip or knee, spasms, right? What about people who are on diuretics? You're on fluid pills, and your fluid pills alter your electrolytes, right? So their potassium is low, magnesium is low, calcium is off. That can cause spasms too, that mimic peripheral arterial disease. Restless leg syndrome, venous disease, which is
one of the most common and prevalent diseases out there right now that most people do not know how to work on. Next slide. So what are your treatment options? You have to know these. Not everything is a procedure. First, you can treat with medicines. Lifestyle changes is your number one option, okay? Quit smoking, lower your blood pressure, lower your cholesterol levels, manage your diabetes, right? Your A1C needs to be less than 7%, that's our goal. And for every pre-diabetic, you tell them to decrease their weight by 5 to 7% so they don't become a diabetic. Healthy diet, regular exercising, and then medications. We want to make sure that that plaque builds up, so statin therapy, antiplatelet therapy is initiated so that their platelets don't start sticking and that plaque does not get worse. It becomes stable and it does not destabilize, all right? We manage the diabetes and we decrease their symptoms. Then if that fails, then we go into procedures where, just like a plumber is called to unclog your pipes when it's clogged up at home, you come see someone like us where we can go in and literally unclog those pipes for you. Those are options before an amputation. That can be done minimally invasive or surgically, but you do not want to chop off someone's leg as a solution to a clogged artery. A plumber doesn't just come to your house and take off everything in the kitchen and says, you know what, that's the solution to a clogged pipe, right? No. Same thing with the legs. Because remember, 80% of them will die within 5 years. Next slide. So, if I were to tell you all that, do you know that 80% of all amputations in America are done without someone shooting dye down their legs to see if it's clogged or not? They just go and chop it off. That's it. Do you know that? Yeah. That is the number one treatment. And you know what? All y'all who say no, yes you do. Because you know the state that has the highest rates of amputation in America? There you go. That's why I'm here. That's what made me move here. Yep. Number one. Do you know what actually, where in Mississippi has the highest amputation rates? There you go, the Delta, the core of the Delta. So, I can tell you that over 90% of the amputees I've seen who've had a major amputation in this Delta have never had the privilege of having an angiogram. And even though I've given this talk nationally, whenever I make that statement, my blood pressure goes up. Because 80% of them are dead. Those are 90% of those lives that are dead could have been prevented. So that is the consequence of us not facing this head on, not having preventative strategies upstream. Next slide. So I'm not just saying this alone. Even the U.S. Surgeon General, the person who's in charge of healthcare, said this. The U.S. healthcare system spends $800 million a year on amputations. Actually, that number is wrong. It's $2 billion, actually, not 800. Why do we have a system that pays exponentially more to amputate a foot than to prevent or address the diabetes that leads to the amputation in the first place? Do you know the answer? Because every system is designed to get the results it gets. So we have a healthcare system that is a sick care system, not a preventative care system. Next slide. And that's why you see this all the time. These are pictures that I take. I always take pictures of patients who present to my practice, and this is the first visit with me. This should not be the case. These are people who have the same hopes, fears, dreams, people who are your mothers, your brothers, your sisters, your family members, your cousins, your neighbors. Next slide. And so the answer is that, okay, where have we failed? We failed in addressing the number one cause of health disparities in America, and that is social determinants of health. Social determinants of health are basically, just a bunch of metrics that basically determine how well you do from a healthcare standpoint based on your economic status, your educational status, your physical environment, your access to food in terms of food security or food insecurity, right? It has to do with your community, your social context, and that's not just only support systems that you have around you, but how community engagement occurs around you. Are there any discriminatory practices or stressors? Are there environmental causes for your health outcomes? And then also your healthcare system. Do you have access to insurance? Does your doctor care about you? Do your nurses care about you? Are there available providers where you are? or do you live in a specialty desert? You know, we talk about food deserts, but specialty deserts, where you can't see a doctor. You gotta drive 2 hours to go see a doctor. Where's that common? Mississippi, right? Providing linguistic and cultural competency and quality of care. I tell people, access to care is not the same as access to quality care. Your first line of contact, wherever you go in the healthcare system, will determine if you live or if you die, or if you lose your limbs. So if you walk into any emergency room and a nurse gives you the wrong medication, you can die. If the doctor orders the wrong study, you can die. If the doctor orders that you get an amputation and you say, yes sir, yes ma'am, you will die. That is, you had access to care, but it was not necessarily access to quality care. Next slide. So, I'm sorry, go back one more. Go back. 80% of health inequities in America are due to the first 5 columns. Only 20% is due to your healthcare system. So, with all the great instructors you have here and this talk as I'm giving to you as a doctor and my nurses, we can only control 20% of this. So that is why we need other people involved in the care. This is a shared decision-making process. I gotta know how they're taking their insulin. Can they afford the insulin I prescribed them? When I say go work out and go exercise, right? As cardiologists, we always say that, go exercise for 150 minutes. So, ma'am, go exercise. Do they even have a walkway or a park that's safe to go exercise? I mean, think about the communities we live in around here, right? So, that's something, how many people have medical bills? 7 out of 10 family members in this state have medical bills. So can they even afford the transportation to even come and see you for their follow-up or for that scheduled procedure? So those are some of the challenges that our folks are facing that we as providers now have to start thinking about. Not just diagnosing the problem and writing on the script and saying, hey, you were non-compliant because you didn't show up or you didn't take that medicine. Next slide. So I always say this, medicine encompasses the power of mankind to do good, to heal, but to be humanistic. And next slide. And when it comes to humanistic, you always think about equality versus equity. So just because I prescribe a one brush answer for a problem, and I say, hey, listen, all y'all are gonna get $100 to solve all your problems today. Everyone gets $100. So what did I do? I just created equal opportunity based on $100. But that's not equity. Some people need more than that. So it's not just financially, but some people have been led back historically where you have to give them additional support systems. And sometimes it's multidisciplinary, so they can catch up and live to the same standards they need to. So it's all about different supports so that you can give them equal access to the same treatment, or in this case, so that that little kid can see the game, right? And when you take away all those systemic barriers, that's when you have equity. So always know the difference between equality and equity in wherever you go to, because that term is something that will follow you for the rest of your careers. Next slide. So, sympathy, empathy, and compassion. I'm very, very passionate about this topic. Why? Because Mississippi actually made me understand the differences. When I came in as a Yankee, right? Because I'm from up north, so they call you a Yankee when you come down here, right? So when I came as a Yankee, it was like, all right, you know, why don't they use all the advanced medications? Or when you talk to a patient, just say, hey, listen, go exercise, and they come back, and you know, you just start talking. You speak at them. You're not speaking to them. You're not coming down to their level. You're not understanding the community. So what I had to do was I really had to understand. Literally, I bought a map, and I still have this map. I showed it to I bought a map to understand the whole entire Delta, where people live, who's what, the strengths and weaknesses. I engaged myself in a lot of churches around here just to go talk to them about things, but also learning back from them. And so it became just, you know, feeling with the patient, understanding some of their challenges. You visit them where they are. But then after you have that empathy, the compassion is, what did I do with it? What is the action behind the empathy? You can say I empathize with you, but I go home, I watch my TV, and I go to bed, and the next day I come to work, and I say I still empathize with you. But what have you done with your platform? What have you done with that information? What have you done for that patient? What have you done for people who lack a megaphone? So that is a huge difference. It's not just advocacy, it's action on top of the empathy so that you become that compassionate provider. And please, all of you in this room, just wherever you go, I don't know where this is gonna lead, just remember, I don't want you to just be empathetic. I want you to be a compassionate provider. Next slide. And so, competency, you're all gonna be competent. Why? Because I know about this program. I've heard about this program from day one. It's solid. Yeah, you come out of here, you'll be well trained. Trust me, I work with the grads, right? So they're gonna be competent. You're gonna listen to your patient's needs. You're gonna become an advocate. You'll have knowledgeable, information regarding the disease states they come in. You're gonna have that emotional quotient or emotional intelligence that's required to take care of the patient and to listen to them and become that empathetic and compassionate provider. You're gonna be resilient, right? Because you've gone through this program. Resiliency is something that you'll have, right? Critical thinkers, cultural awareness, and confidence. Okay? What doesn't break you will only make you stronger. You have to know that. All right? Not everything is about a grade, by the way. Okay? It's about what you earn and what you learn and how you became a compassionate provider to take care of every single one as if they're your family member. Next slide. And then the benefits will come. You're going to trust not only yourself, but also your treatment plans. You become more confident the more you treat, the more you extend. You enjoy your job. Enjoy it with gratification. You're going to spread that joy and positivity, and you're going to fuel your patient's experience by becoming the best that you can be. Next thought. But just remember, it's the action. So for me, what I had to do was I learned about what was going on here. I publicized it, but then I wrote about it, and I went to different forums to tell the story about how people are losing their limbs without appropriate care. And it got picked up. People wanted to hear more about it. So that's the action, is to go to Men's Health Magazine or Reader's Digest, and they said, yeah, yes, we want to hear about this story. Or you go to the halls of Congress and they want to hear about this story. So that's what we did. Next slide. But don't always forget about home. Because as much as you're doing that, your day-to-day is still about awareness, awareness, awareness. 1 in 4 people know about this disease. This is a patient who basically, military wife, diabetic for a long time, had a stroke. Remember that first slide I told you about 30 to 50% will have a stroke. She had a stroke, and so they attributed her disability to her stroke. No one had screened her for peripheral arterial disease until we met her at a community event, and we screened her. Next slide. And 2 weeks after, she's in my office standing up for the first time. Because she had 100% occluded artery that we opened up. Next slide. So, we decreased amputation rates by 88%. We published it by doing these angiograms on patients. They were doing amputations as high as 56, and we brought it down to 7. Next. And now there is an Amputation Reduction and Compassion Act that's in legislation right now, where it's authorizing funding to establish and coordinate PAD education, just similar to what I've done, but on a wider scale, not only to curriculums, but also through HHS, which is basically a government agency. And it established coverages for PAD screening and testing at no cost to the patient, because remember the economic inequities that exist. You don't want them to pay for it. And it disallows payment for non-emergent amputations in those patients who've never had things like an angiogram or an ultrasound. So there's no way that we as doctors should be getting paid for procedures if this patient could have been prevented from being amputated. So it sets those stopgaps upstream. And then it requires the development of quality measures. Bipartisan effort currently in the halls of Congress. Next. So almost in closing, we're done. What do I think about when I think about our healthcare system? This is something that I want all of you to remember. Because some of you are going to come out here, and some of you are going to be technically competent. And some of you are just going to be interpersonal competent. Some of you are going to have both. But remember what you love. Remember your mission and your passion. Remember what you're great at. Not everyone has the same gifts. But just remember what you're great at, but also remember what the world needs. combine all of that, add that to either your vocation or your profession or what you're paid for, but just assemble a compassionate team. And once you do that, I promise you that you'll be able to affect change in a positive manner wherever you land. Next. So put your passion and your purpose together. Others will follow. Next. Thank you for your time. We have questions. Right? How are we going to do this? The questions. I ask, and then we... Okay. All right. Oh, she's going to come down? Okay, good. Now, should they ask me questions first before I start asking questions, or how should this work? Does anyone have any questions for me based on this talk? Where am I located? Good. Does anyone want to tell them where I'm located?
Cleveland and
No, can you
Clarksdale.
stand up? She can't.
Cleveland, the road
Stand
behind
up, Whitney.
Walmart,
Stand up.
and Clarksdale, across from Yazoo Pass.
She's shocked. I am located in Cleveland, Mississippi. Okay. The address is 800 North Pyramid Avenue. For those who are familiar with Cleveland, you know where there's the
road behind
the
Walmart.
route behind Walmart. That little strip. It goes into Martin Luther King. Yeah, it switches names from North Pyramid into Martin Luther King, and you'll see the hospital actually close to you if you passed it. But that's where it is. It's behind there. Our phone number is in the beginning of this slide. We'll put it up again. They'll give you my business cards, okay? And then also we're in Clarksdale, downtown Clarksdale, the old Regions Bank, all right? So those are our two sites. I am a clinician, so where we do clinic, I also do procedures, so it's an outpatient-based lab as well. So people who are interested in doing procedures. I have 40 employees right now. I brought, how many of y'all here? 7 today? But it's a fun experience for nurses who want to learn not only how the clinic works, but how sedation works, like how you take care of patients who are in your cath labs. So that's kind of what we do, all right? So does that answer your question, ma'am? We'll give you cards too after this, all right? Next. Any other questions? Yes, ma'am.
Do patients have to have a referral from a provider to see you, or can they just make an appointment?
You want to stand up and answer that now this time?
It depends on the insurance. Some insurances require it. They have to have one, and certain insurances, mostly like Medicare, Medicaid, most of those don't require it.
So if they're Medicare, Medicaid, they can just make an appointment?
Right,
If they're,
right.
like,
But they do tend to get in quicker if we have a little bit of background on them, so we know exactly what they're coming for. So that's helpful in getting them in sooner.
What I always tell people is just if they can call the front desk and just say, hey, listen, this is what's going on, this is my status. Do I need a referral or not? We never tell a patient no. I'll tell you this much. They know the rules. Everyone has to be seen, irrespective of status. Some people require referral based on their insurance statuses. But for the most part, majority of my patients, 75% are Medicare, they don't. Any other questions? Yes, sir.
How many procedures do you do in a year?
Okay. This is what I brag a little bit, but and I only brag when we talk about procedures. So last, we are the top out of every lab in America. We're top 3. I did I've done 2303, so 2,303 procedures since 2019, since we opened up. Okay, so in 2.5 years, we've done 2,303 procedures. That does not include what you saw at Bolivar Medical, where I've done over 1,500 procedures there. So that's how many procedures I've done here in the Delta since I arrived. We decreased amputations by 80%. Our success rate is about 96.5, 97%. That means that the only other 4% will require some form of bypass or came to me too late where an amputation is their option. And we just recruited a podiatrist. So we have an on-site podiatrist now. Podiatric care is on-site. So for those who are interested in podiatry as well, you can come and shadow as well. Does that answer? Good. Next. Okay, let's ask questions. All right. What are the risk factors for peripheral arterial disease? She raised her hand first. What's your name? Stand up, young lady. All right. Anna? Okay, Anna. What are risk factors for PAD?
Smoking,
Yeah.
diabetes, hypertension, and age and race.
Good.
Good
Good,
job.
good. Okay. All right. Family history. Don't forget your family history. All right. Family history. Now, smoking. Let me just teach y'all something about smoking. A lot of folks around here actually don't smoke. You know what they do? Vape. Actually, the vaping is not they dip. There you go, dip. How many of you are involved in research? Any of you have done research? If you read any research study, I dare you to go read and say, oh, we had 20% who dipped and 50% who smoked. It's not asked in research trials. You know that, right? So a lot of the trials that are done to date do not include patients who dip or vape. So when y'all are asking your questions to your patients, when you go on your clinicals, don't just say, do you smoke? Do you smoke? Do you use any tobacco products? Do you dip, chew, vape? Like, just get it all out, all right? Because you'll be surprised as to what they tell you. If you just say smoking, don't say, well, you didn't ask me if I dip or if I chew. Remember, come down to their level, all right? Okay, good. Name 3 cardiovascular diseases. Hold on, she was first. All right. What's your name?
Savannah. Okay, coronary artery disease, peripheral artery disease, and then stroke.
All right, come on, fellas, we gotta do better. All right, what percentage of patients die after? Hey, yep, the guy in black. I'm sorry. What's your name? Justin. Justin. What's up, Justin? Man, Justin, you sound like trouble, man. You see trouble? I just know one when I see one. What's up? What's the number, Justin? 80. That's my guy. There you go, Justin. All right, Justin. All right. Number 4. Name 2 social determinants of health. Okay, young lady, stand up. What's your name?
Janet.
Janet. Okay.
Education and nutrition.
Food. Okay, good. Food and education. All right, you got that right. Economic status, education, food, access to food, right? The physical and neighborhood. So just your physical space. Okay, remember housing, transportation, all that. Your community context in terms of where you live, and then the healthcare system. All right. All right. Good. And 5. What percentage of patients are more likely to have PAD if they already have coronary disease? Someone from this side, come on. Raise your hand. Just raise your hand and give me a percentage. It ain't that hard. Just no one?
Sorry. I think it's 40%, and my name's Molly, but I don't
Hi dear, how are you? Well, it's not 40%, but you know what? Were you the only person who raised your hand? Oh, okay. She raised her hand. I'm sorry? 70%. Both of you are very close. Well, 90. It's 80%. I'm sorry. Who raised it? Oh, wait. Oh my gosh. I'm in trouble. Oh my gosh. Okay. We need to. You know what? Don't worry. You know what? Everyone wins, but she raised her hand too. Oh, she raised her hand too. She got the answer. The winner's over here.
Haley.
Don't worry. We got you. You know what? We got everybody. If not, we'll get your address and we'll mail your t-shirt. Okay? For everyone who gets the answer, you know what? Even those who guess 40, 70, you know what you're gonna do? Get their addresses. I'm gonna mail your t-shirts. 1, 2, 3. Okay, the ones who got 40, 90, and 70. Yeah, whoever got it, they're gonna get gifts. You know why? Because they spoke up. Y'all gotta speak up now. All right, next. All right, this is the last question. What's the answer? What's the answer? Raise your hand. Yay! What's your name? Joyce. Well, stand up, Joyce. There you go. There you go. So, hey, this is a good one. Y'all should. Anyone who wants to go into cardiology, you have to know this fact. All right, a lot of people don't know this, but The heart weighs less than a pound and beats 100,000 times a day. And the vessels that are over 60,000 miles long are what? Your arteries, your veins, and your capillary system. Everyone forgets about the capillary system. And I can tell you a lot of diseases that just only stem from the capillary system. If you want to go into some cool stuff, the capillary system is a whole different bucket. And you can be a great capillary because there are only about less than 100 specialists that actually intervene on the capillary system in the country. All right, so that is the heart. Thank you very much for the invitation. It was fun talking to y'all. If y'all have any questions, and for those of y'all, we'll get you your t-shirts, I promise you, okay? All right, good. Wait. Oh, do I announce that last? Do I tell them?
If you want to.
What?
So everyone gets a gift. It's Valentine's Day, right? I brought all y'all gifts.
It's like Oprah, only better.
You all get a gift, all right?
Everybody gets
So everyone gets a happy, all right? Good.
Look, the